Some of you might recall the first generation of customized crosslinking that was published by Theo Seiler Jr. back in 2016, and that was a very nice idea. So what Theo did is he said, crosslinking flattens the cornea. So why don't I use different levels of crosslinking over different areas of the cornea? And then he saw very nice predictable flattenings of 2, 3, sometimes 4 diopters. And we all know when we do crosslinking, this sometimes happens spontaneously, but you cannot predict. Here, you can predict that there will be a flattening. How did he do this? Well, he used a big machine with an eye tracker, and it is an epi-off procedure where he used more energy over, I think at the time, he centered over the posterior float of the keratoconus. So this is where he gave the most energy, and then he created gradients of intensity. And this is how he was able to flatten the area of concern, the keratoconus, more than the rest. Now, what we developed, we call second generation customized crosslinking PACE, and we are 3 to 4 times more efficient with a tiny machine. Let me show you how. This is the first generation machine. It has an eye tracker, and it's not available anymore. Avedro abandoned the technology once they were bought by Glaukos. So you can only get a used machine to do this first generation crosslinking. PACE, on the other hand, gives you, based on a similar concept, massive results. This is PACE 7 days after. And this goes along with an increase in spectacle corrected vision of 2 lines, 3 lines, 4 lines, sometimes 5 lines. Let me show you another example. That's a beautiful one, bilateral PACE, 4 weeks later. The cone is almost eradicated. And the big difference towards PRK is the corneal wavefront guided PRK, that's one of our patients, does something similar. But the big difference is in PRK, I remove tissue. In PACE, I do not remove any tissue. It's the same tissue, I just flatten. How did we do this? Well, we had help using these 2 devices on the sides. We used the Shunt Amaris. We used our crosslinking technology, also produced by CSO Italia, and the MS39, the epithelial maps. By combining these 3, we were able to get these amazing results. And one hallmark is we can take the CI, which is also outside in the hall, and put it under the Amaris laser since a little more than 1 year. So we have a crosslinking device in combination with the laser. And PACE stands for PTK-assisted customized epi-on crosslinking, because the backbone is our newly developed epi-on. And this epi-on, may I ask you, which is the most common crosslinking protocol you use in your daily practice? Most of you do epi-off, right? Probably. Is it the Dresden protocol or the 10 minutes protocol? Which one do you prefer? I know, but which one is your regular, the 10 minutes? Me too. Until we developed the epi-on, I used the 10 minutes for every normal keratoconus, and for aggressive cones, I went back to Dresden. Now, this epi-on we developed is as strong as the 10 minutes epi-off. And we just submitted the lab data, and we are publishing the clinical data in the next weeks. Took us a few years. So imagine you do an epi-on that is really solid, good, like the 10 minutes epi-off. But then, so this is an epi-off, the epi-on that does not need iontophoresis, that does not need oxygen, because we wanted to keep it as simple as possible. But then, on top of this epi-on, we create a custom PTK that is epithelial map driven. So we take the MS39 data, and we create a small window of epi-off over the cone. I will show you how. So this area is epi-off. Now, if I treat the entire cornea with my epi-on, no matter how the settings are, the small window will react even more, because there is no epithelium. So there is more energy, there's more riboflavin. So we create this small PTK. I'll show you how. And then we drop riboflavin. What will happen? We developed an epi-on that lets riboflavin pass through the intact cornea. So everything will get saturated, but over the small window, there will be more riboflavin going in because it's easier. So what you will create is the riboflavin will go in even more in the epi-off area and then go down into the sides. Goes down into the sides. And the longer you wait, the more it will spread, but the concentration will be less and less and less. And that's the second gradient. More riboflavin, more crosslinks, more flattening. Less riboflavin, less flattening. And in the end, we retreat the PTK area with even more fluence, with even more energy. So when you look at the patient, you see an interesting mixture of a small epi-off zone and an epi-on zone. Let me show you a short video. This is what you see. And this protocol we developed with pulsed light because we want to have the maximum of oxygen availability present. And this is based on a few years of our epi-on development. So this is what you see. To do this epi-on, we needed to develop a special second type of eye drops, penetration enhancers. We call it second generation because they do not harm the epithelium anymore. That took a long time, and we are waiting for 1.5 years now for the CE mark of these drops. This is why you cannot do PACE yet. We hope that the drops will be CE cleared in the next months, and then you can do this type of treatment. And let me show you results, more results. This is 4 weeks after PACE. And here you see something interesting. The lower cornea gets flattened. But what happens if you push into a balloon and flatten the balloon here? The upper part goes up. That's the coupling effect. Look at the difference map. The upper part here increases. The lower part flattens, the upper part increases, and all of a sudden the astigmatism is way more regular. PRK does not do that. PRK just flattens the lower part. It doesn't steepen necessarily the upper part. Here's another example. 1 week after PACE, and if you look at the area over the pupil, this is very regular. So such a patient, compared to here, has a massive increase in both visual quality and visual acuity. And this is what you get also here after 6 weeks. Again, much more regular over the center, and look at the difference map. And this is why we don't say we flattened by 4 diopters. No, we flattened by 4, we increased steepness by 3, we increased symmetry by 7 diopters, or 10, or sometimes 12. Here's another example where the cone is almost vanished. And how long does it take to stabilize? It takes about 6 months. So this is a quite beautiful result after 12 weeks and after 6 months and after 12 months. It's not a lot happening anymore. We've treated a little more than 200 eyes now with the 1-year follow-up, and it seems to stabilize after half a year. Again, the difference image where you see the coupling effect, quite massive. What about thickness? Measured with the MS39 before and 12 months later, no change in thickness because we didn't remove any tissue. What about the demarcation line? The demarcation line follows exactly the depth of treatment. So in the center, where we have an enormous amount of fluence, we are very deep. And in the periphery, our epi-on is at roughly 210, 20 micron, like a 10-minute epi-off. This whole module was developed together with Francesco Versace, and he wrote a beta software of Phoenix for us. So we have a PACE module. And in that PACE module, where do we center this small PTK? We use the Gaussian profile of the MS39 anterior surface. And then we play with the offset and the size and the shape of the PTK. And the beautiful thing is that the Amaris can take all these values and give you any size and shape PTK you want at any depth. So this is a perfect coupling of different effects. And this is what we then do while we perform the PTK. This was a lot of information. So questions we hear a lot is, why do we need another excimer laser protocol? We have Athens protocol, Cretan protocol, Trek, Sterix, so many different names. These protocols do something totally different. All these protocols use an excimer laser and cross-linking, but the effect comes from the excimer laser. You use a laser to remodel the cornea, and then you say, oh, wait a minute, I removed tissue, I need to cross-link that cornea or it will decompensate. So you remove stroma and you use the excimer laser. Cross-linking is a byproduct you need. PACE is the opposite. PACE uses cross-linking for the effect. And the excimer laser is simply a tool to create the PTK. Out of curiosity, we put a patient in front of the MS-39 5 minutes after PACE. And of course, there is a huge error because there is an epithelium off area. But the principle, for you to see how massive and how immediate the effect is, look at this tangential map before and after. It's like a negative imprint of a keratoconus. It's completely gone. And look at the steepening around. So this is an effect of almost 25 diopters in 5 minutes. We push the cornea down. And then it needs 3 months, 6 months to find a new balance. If you're more used to eggshell, this is, I think, the same patient or a similar patient here. 5 minutes later. It reduces it massively. And we are in the process of analyzing it. Yeah, the increase of symmetry does massive things to vertical coma, spherical aberration, and so on. We have all the data. That's the coupling effect. So where does this PACE fit? We try to also get a more clear idea for this one in our heads. And if you think of keratoconus cornea, the higher up you go, the more irregular. Then what we do now is we use corneal wavefront-guided PRK for the fine-tuning. 10 years ago, this was more or less my only approach. So I knew that I can use the laser up to 50, 51, 2, 3 diopters. But if I try to go too high, I remove too much tissue. So you are somehow limited to do the fine-tuning because you remove tissue. PACE, we see above, because it doesn't remove tissue. We did PACE up to 60 diopters. Now, the beauty is you did not remove tissue. So now we are starting to treat the first patients with the additional wavefront-guided PRK. And we can further improve. And what is above PACE? Rings and femtocares. So I think the future is extremely interesting because with femtocares, you add tissue. With PACE, you remodel without removing. And then the last step would be the fine-tuning with the laser. So we really have much more possibilities than we used to have before. And please don't forget, the flattening is unspecific. I had a question before, how much do you flatten? I cannot tell. We don't have a nomogram yet, and every patient seems to be reacting differently, and it's age-related. We improved some old keratoconus patients prior to cataract surgery, and a 70-year-old reacts less, stiffer cornea, less prone to remodeling. So what we do, we choose patients with at least a decent 50 diopters or more of Kmax. Also for the long-term effects, maybe this patient will continue to flatten over the next 10 years. So I don't want to end up in 30 diopters of K readings. And we try to choose myopic patients because we shift them towards plus. If they are -2, they will probably end up around 0. So in conclusion, we regularize up to 12 diopters. We improve CDVA. You can use it in stable patients, not only in progressive keratoconus. And you can do a wavefront-guided PRK later. A little more than 200 eyes treated. We will publish sometime end of the year. And you need the combination of these 3 things. And the backbone is the epi-on of the CI device. And the epi-on is not CE marked yet. As soon as it is, you can all do PACE if you have these technologies. If you want to learn more, please join us at the 3rd ELSA refractive course in September in Zurich. And this was a joint venture of different parties, many fruitful discussions with Shadi, huge input from Francesco, who is a mastermind behind this. And thank you for your attention.